Howdy, everyone. Thanks for learning about MS with me, Aaron Boster. It's Sunday morning, a little after 7 a.m. Eastern Standard Time. I have got my morning grog and one of my brand new mugs, and I thought I'd jump online and spend a few minutes talking with you guys, answering your questions about multiple sclerosis and kind of sharing what's new in the world of the MS clinic and the research. So I'm hopeful that I can get this chat up and running. You guys know this is not my strong suit. Vicky's online. Good morning, Vicky. Thanks for joining me. A couple ground rules, guardrails as we get this started. For many of you who have jumped on before, hello, Mama Jojo. I hope you're doing well. I hope your son's doing well. I can't answer individual questions online. I can't diagnose you or provide you with a treatment plan by you typing in a few words and then me responding. I have to allow this to be a little bit more generalized, so make sure that your questions are more generalized, please. More people are jumping online. Josh, it's good to see you. Good morning, good sir. Marie, hello, how are you? I've got Janice joining the line. Emily's joining the line from Scotland. If you jump on, please say hello, howdy, hi, and share where you're from. Include your location. It's really fun for me to kind of see where everyone's coming from. I just spilled a bunch of coffee here, but I'll take care of that later. So, what I would like to do is share with you guys a little bit about some of what I've been planning for the channel, some things that you're going to be seeing this coming week, and then to take any questions that you may have. Hello, Angela. Hello, Sweet Dorts. I got someone from Ireland coming on. This is awesome. From the UK, Connecticut, from Holland. Hello, hello. From Louisiana. Josh is calling in from sunny Columbus, Ohio. So late last week, I sent out a Twitter post where I linked an article talking about the need to take disease-modifying therapy. Now, this was an article written in the public domain. It wasn't a scientific article. And it was someone sharing their own personal experience about how they felt taking a disease-modifying therapy was important. And I pushed it forward because that's something that I believe in. I believe that people with MS fare better when they're on disease-modifying therapy. And someone on Twitter sent me a direct message and said, "Hey, take that down. Please delete that article. Don't post that, because not everyone needs to take a disease-modifying therapy. And in fact, it's a valid option not to. And in fact, it's just as safe not to." Well, I lost my mind. It's not safe. It's not a valid option. I'm not okay with that. I would not take it down off my Twitter account. And in fact, it prompted me to make a video, which I'm excited to post tomorrow morning. So a sneak peek, there's a video coming out tomorrow morning about 8 o'clock where I jump in headfirst and talk about why I disagree and why I feel that people with MS should be on a disease-modifying therapy. I talk a little bit about the reasons behind that, about the philosophy behind that, about how it helps set the stage for years and years of disease to come. And I go through some of the most common reasons patients share with me, well, I can't do it. Talking about issues of cost, tolerability, and safety. So I'm really excited for you guys to check that out. If you get a chance to look at it, please leave a comment down below and let me know your thoughts. It's definitely my own personal opinion, but it's one that I wanted to share with you guys. So looking here, I've got folks from Pittsburgh, Pennsylvania, from Australia, from Norway. This is so freaking awesome, guys. It is so heartwarming that there's this amazing online community of people impacted by MS who are banding together to create this online village. I love it. I love you guys. And thank you very, very much for helping make this so powerful. So I've got someone who writes in here, "Hello, sir. I have optic neuritis in one eye last month and treated with Solumedrol injections. What's the chances of developing it in the other eye?" And so that's an excellent question. Optic neuritis is an inflammation of the nerve that runs the eye. And it's not an uncommon symptom in MS. It can be seen rather frequently. Fortunately, the likelihood of bilateral optic neuritis is very low in MS. And I mean sudden presentation. That's not his question. But where suddenly both eyes have optic neuritis, that's seen way less than 1% of the time. If you have optic neuritis in one eye, it's a crapshoot whether you're going to have it again, and it's a crapshoot whether you get it in the other eye. I'm not aware of any statistics that predict that if you have it here, you're more or less likely to get it here. But I'll share with you that that's not common. I really would recommend that you embrace the idea as follows. I don't worry about the flat tire I don't have. So I don't worry about a flat tire before it occurs. If I'm driving down the freeway, I don't ask myself, did my front left tire blow up? On the contrary, I don't worry about that. If, God forbid, the front left tire blew up, I'd pull over on the side of the road. And I remind my patients, I'm your mechanic. And so if, God forbid, you were to have that happen, optic neuritis in the other eye, we would obviously want to treat you. But I wouldn't walk around with fear and concern that it's going to happen, because statistically, there's nothing saying that it will. That's a great question. Thank you for asking. So I've got Toledo, Ohio up in here. How are you? Allison from Oxford, UK, from Slovakia. This is really exciting. Hello, everyone. Good morning. Let's see. Can MS cause you to feel like you're having some sort of seizing feeling in your arms? And so the answer is yes. I interpret seizing feeling to mean that it's tight and it doesn't move and it's seized up. And I have a lot of videos on my channel where I talk about spasticity. Spasticity, which occurs in upwards of 70% of people with MS, is a problem with the coordination of your muscles. And so I'll use my massive arm here as an example. So if I want to bring my arm forward, my bicep has to get shorter and my tricep has to relax. Both things have to happen. Bicep gets shorter while the tricep relaxes, which allows me to bring my arm forward. Now, I don't say bicep contract, tricep relax. I just say, coffee. My spinal cord and my brain coordinate the movements between my tricep and bicep, which are opposing muscles. In the setting of MS, there can be damage to the brain and spinal cord, which can interfere with that. So when you want to bring your arm in, you also want to bring your arm out. And you really set up a tug of war between the two muscles. And that tug of war manifests as limbs that are hard to bend, spasms, or cramps, like a Charlie horse. And so, yes, you can see that. Absolutely. It's very common. It's typically worse when it's cold outside, and it's worse when you're still and haven't been moving a lot. And so you may find that that's the situation that you're in. Keeping the muscles warm, stretching can be very, very helpful. Staying hydrated can be helpful. And then there are many, many medicines that you can take to help with that problem. Thank you for asking it. Josh Verdi writes a question. I suffered a head injury a couple of days ago. The ER ruled out concussion and optic neuritis, yet my vision is still messed up and I'm dizzier than I was before. Could this just be inflammation? Wow, Josh, I am really sorry to hear that you suffered a concussion. That stinks. And sometimes nature's too generous. You can have MS and suffer a concussion. If you banged your head, you're at risk of having some residual deficits for a couple of days or weeks. And if you banged your head and you were knocked out, that's even higher risk. And so when they say they ruled out concussion, I don't know how you rule out a concussion. I think that you could rule out a bleed, you could rule out a structural injury, but the residual damage from the head injury might last for days or weeks. And so I'm really sorry to hear that you're feeling dizzy. That stinks. If it's getting worse, you want to reach out to your providers and see how they can be able to help you. But hopefully this is something, Josh, that's going to resolve itself over the next couple of days to weeks. I wish you the best of luck, and I'm sorry that happened to you. So Mama Jojo says that she loves the flat tire analogy. Thank you very much. Brad says, why does an MS attack sometimes cause part of the face to go numb? Well, Brad, multiple sclerosis is a situation where your immune system beats up portions of your brain and spinal cord. So the central nervous system. Now, the brain quite literally is the supercomputer that runs the body. And it controls the functions of everything, including facial movement and facial sensation. And so if the part of the brain that controls facial sensation becomes inflamed and impacted by MS, then that portion of your face can be numb. And it's a result of damage to the brain in the circuitry that provides sensation to your face. So we absolutely can see that in the setting of MS. So jumping into some other questions, Lena writes in, do you recommend ADHD medicines to treat fatigue? So I have many videos on my channel about combating fatigue, talking about sleep hygiene and the importance of exercise and minimizing sedating medicines, avoiding excessive drugs and alcohol, managing depression. There's a host of things that we do to optimize fatigue. And yes, drugs can be helpful. And so ADHD medicines are typically stimulants, things like adderall and Ritalin. And it turns out that giving someone with MS fatigue stimulants can oftentimes markedly help their fatigue. And so we use two classes of medicines. One is the stimulants, the amphetamines like Ritalin and Adderall that I just described. Now, these are controlled substances in the United States, and they are the most abused drugs on college campuses. And so we have to keep that in mind. If you take them religiously without a day off, you can develop a tolerance. And so many of my patients need to take a weekend off or a Sunday off to kind of reset. We also use some medicines called Provigil and Nuvigil. Those are cousins. Modafinil and armodafinil are the generic names. And they work slightly differently, but with many, many of the same outcome. And these medicines can be life-changing in helping someone with MS pathologic fatigue. But like I said, we don't do it in isolation. We just don't throw a pill at someone. We do medicine along with the behavioral things that I mentioned. Excellent question. Thank you. So I've got Sarah on the line who says, what do you think of special diets like paleo? So that's a great question. Many people, when they find out that they have a chronic condition, one of the first things they do is they say, I'm going to clean up my diet, which is an excellent thing to do. It's great to have a clean diet. And I've done several videos talking about diet. It's a bone of contention for me because, as I shared in a previous live stream, and there is no diet that has been proven to slow multiple sclerosis. There's no diet that has been proven to slow multiple sclerosis. There's a bunch of diets that have proposed to be able to do all kinds of things. And some people have written books that they sell you for money, where they'll teach you that if you eat certain things, then your MS is going to end up better. And that strikes me a little bit like false hope. I really have trouble with that. Now, the question here was, what do I think about a paleo diet? A paleo diet is a diet where there's not a lot of processed sugars, there's not a lot of grains. It's mostly vegetables and meats and fats and things like that. And a modified paleo diet has been suggested to improve energy levels. There are studies ongoing right now looking at a modified paleo diet to improve fatigue. If you would enjoy a modified paleo diet and your fatigue is improved, I think that's awesome. But I don't want you to engage in a modified paleo diet thinking it's going to slow your MS. Now, I'll share with you that I, Aaron, personally eat a modified paleo diet. That's my preference. When I do that, I feel like I don't put on as much weight. I don't feel as bloated. I feel like I have more energy. I feel like I sleep better. But I don't want you to do it thinking that it's going to slow down your MS. Thank you for asking the question. So what else do we have here? Allison writes in, do you have any advice for coming off fingolimod or Gilenya? Same fingolimod or Gilenya. How do you decide? How do you do it? Should it be phased out or gradually? Any advice would be greatly received. Well, let me share with you, Allison, some comments and some opinions. So Gilenya, which is fingolimod, is a great drug. It's a once-a-day pill for MS. It came out in October of 2010. I was involved in some of the clinical trials, and I've certainly used a lot of it. Over the years, I've done advisory work for the company. I've lectured for the company. I really like fingolimod. It's a solid drug. And in my opinion, in 2019, I would say it has a mid-range efficacy, sort of maybe fourth in line, in my own personal opinion. Now, you take Gilenya once a day, and coming off the drug, there's a couple things that you have to keep in mind. First off, the way that Gilenya works is it puts about 80% of your white blood cells inside the lymph nodes. It kind of traps them in the lymph nodes. It doesn't kill them or murder them. It just keeps them in the lymph nodes. So as long as you keep taking the pill once a day, you don't have 80% of those lymphocytes circulating in your body. When you stop Gilenya, they slowly come back out. And it can take 2 to 3 months for your cells to exit the lymph nodes back into the bloodstream. Depending on the next drug, depending on the drug that you're moving to, that may or may not be a problem. For example, If you're on Gilenya and you've moved 80% of your lymphocytes into your lymph nodes, and you're going to go on a drug like, say, Trotta, which kills white blood cells, or Ocrevus, which kills white blood cells, you don't want to give those drugs right away, because if you give it the day you stop the Gilenya, the cells haven't come back out yet. And those drugs that I just gave you examples of, Trotta and Ocrevus, they can't go in the lymph nodes as well as they can go in the bloodstream. So if you stopped Gilenya on day 1 and gave Trotta or Ocrevus on day 2, you wouldn't have a complete kill. So instead, you need to wait for the cells to come back out in the bloodstream, so then those new drugs can get them. But it gets trickier, because there's been very rare, and I think like 6 total cases ever out of over 190,000 people treated, stopping Gilenya, there's a rebound. And so you don't want to just wait forever and ever. And so this puts us between a rock and a hard place. And I'll share with you how we manage it at my shop, where I work at Ohio Health. What we do is we stop Gilenya, and then we'll check a blood count once every 2 weeks or once every month. And that way we can kind of see where the cells are, and we can see when they return, so we know when the cells are back out in the bloodstream. Now, that's not all we do. We also give a pulse of steroids. So once a month, we'll give you a gram of solumedrol, whack, which kind of suppresses the immune response temporarily. And then as quickly as we're able to, we will transition you over to your new drug. So let's use an example that you're on Gilenya and you're switching to Ocrevus, right? So you're going to go from Gilenya to Ocrevus in this made-up example. We would stop the Gilenya, and a month later we would give steroids, but first we would check a white count. And if the white count wasn't back in the normal range, we'd wait another month, check labs. And if they still weren't back up, we'd give another course of steroids. But if they were back up, we'd give Ocrevus. So we want to minimize the amount of time possible. And we're definitely going to make that transition in under 3 months. Now, that's not scientifically proven. That's not gospel. That's not my recommendation for you. That's just what we do at our shop. And it seems to work really well for our patients. Now, knock on wood, we haven't had major issues making that transition. That was a great question. Thank you. So Mama Jojo writes in, what are your thoughts regarding medical marijuana treatments? THC-free CBD oil versus THC-induced CBD oil. So great question. Medical marijuana is a very hot topic. And right now in Ohio, there's a lot going on trying to figure out how to apply these laws and so on and so forth. Now, I'm not going to talk too much about it, but I am going to make a plug. March 2nd, which is creeping up on us, Ohio Health MS Center is putting on a really big patient symposia here in Columbus, Ohio. I'll try to include some links in the post if you want to see what that's about. And this is going to be a really exciting live event. We've got about 8 of our practitioners that are going to each be giving lectures on really cool topics. I have colleagues that will be talking about biomarkers like neurofilament light chain, talking about supplements and vitamins to slow MS. We're going to be talking about stem cell transplantation, and I'm going to be talking about cannabis. And so I've been diligently working on a lecture looking at cannabis, getting into the details of your question of CBD and THC, et cetera. And so I'm really excited to share all that information. I'm going to hold off on launching into it. I'm sure that after the lecture, I'll do some more work here on YouTube, kind of conveying a lot of that information. But I'm going to make you wait until then. So just right around the corner, March. So Judith writes in, it's been such an uphill battle to understand the crazy world of MS since the diagnosis. Discovering your posts have been a godsend. Wow. Well, that's very, very nice of you. Thank you. You know, I started this channel a couple years back to try to help my own MS clinic patients learn between their visits. My rationale here is if I see you 4 times a year, that's twice as often as the average MS patient is seen in general practice. And so at first blush, you might say, oh, wow, that's really great. Well, not really, because you have MS 365 days a year, which means 361 days a year, you still have MS and you're not at the center where we can help you. So that's a bad situation. I mean, this is a chronic condition, and in order to succeed, in order to thrive despite having MS, in order to be the most awesome version of you despite having MS, we have to have some major education. We have to constantly be updating you and upping your game and teaching you. And we can't do that if we see you once every 3 months. I mean, think about this. If I was to try to teach you the game of chess, a game that I love very much, if I was going to teach you chess, but I only met with you every 3 months, I don't think you'd be very good at chess. And I need you to be really good at MS. And so I was looking for ways of educating in between visits. I started off using social media with Twitter and then with Facebook. And I still maintain Twitter and Facebook. If you guys would like to follow me on Twitter or Facebook, I'll leave links down in the section below in the post. But YouTube really hits the mark because YouTube allows me to record myself sharing patient education, literally the same stuff I say in a clinic room. And it allows me to record it and then publish it online. And the value of that, in my opinion, is that then you can learn about it when you want to. So if you were in clinic with me and I shared a concept or gave you information about a new product or something, and you're at home thinking, what did he say? Well, then you can jump online and listen to it again. And it struck me as I started to make these videos, of which there's now like over 200, that it's not just the folks that are in clinic that can benefit. Here on the call, we have people from around the world, and that just makes me feel awesome. And I really, really like this venue. Now, I can't share medical advice, and I'm never giving you guys medical advice. You should do this. You shouldn't do that. I can't make those comments without seeing you in clinic, without examining you, without reading your thorough history, without looking at all your laboratories. But I can share with you general medical education about MS and how to make yourself more awesome despite having it. And so thank you for that kind comment. It's comments like that that invigorate me and make me want to keep doing this. And so thank you. All right, so let's take a couple other questions. Gia writes in, does the XR Adderall work in MS patients or just the immediate release kind? So there's nothing special about having MS which would make an immediate release pill or an extended release pill work or not work. And really it's very individual, very individualized. We have some people that take an immediate release stimulant in the morning, they take another one in the afternoon. We have some people that just take it once a day. And we have many people that benefit from extended release where they feel like they have better coverage throughout the day. And that's just very basic pharmacology. That's applying the right formulation of the drug to the right patient. Emily writes in, I was offered to start research where I've to answer questions every 3 months online and allow docs to see any changes. So it offers them an extra dose of information. Ellie, that's awesome. That's a wonderful way of communicating with doctors. And it's very, very kind of you to volunteer yourself and your answers to help us learn. And think about this for a second. Here in the United States, we have 17 different flavors of MS medicines, which is really wonderful, considering in '93 we had none. And we wouldn't have those medicines if people like yourself weren't willing to contribute and to fight back and to donate portions of their thoughts and of their bodies so that people can learn, so that we can learn whether these drugs work and how best to apply them. So let's take a moment and just say thank you to people with MS that have been willing to volunteer for clinical trials. It's because of those people that we have these drugs available and that we know what we know about MS. And it really is something very special for people who have yet to be diagnosed. They will come into this disease with options available because of people with MS before them that volunteered for research. So thank you very much for doing that. It means a lot to me. Thank you. All right, so what else do we have cooking here? I'm reading through a couple questions. Phelan writes, is giving plasma bad? I did that a lot before I knew I had MS. So giving plasma is not bad. There's a couple things that you need to think about. Some of the medications that we take for MS sit in the bloodstream. Some of them are biologic agents, some of them are not. And if you're thinking about donating blood, first of all, that's really nice of you. We have a national shortage of blood donation here in the United States very frequently. Working in the hospital all the time, I hear the announcements overhead, shortage of blood, we're running a blood drive. And so if you want to donate your blood, I think it's really cool. It's appropriate to ask your MS provider beforehand. Say, hey, I'm thinking of donating blood next week. Does it matter? Now, you having MS makes no difference. Having MS, you could donate blood every day. But the medicines that you take may or may not create an issue for donating blood. And so just check with your provider prior to going to donate blood. Having MS doesn't create a problem, but certain medicines that you're taking may or may not be a concern. So check that out. Great question. Thank you. So Susan writes in, have you experienced any great improvements in people with severe cognitive impairment? So that's a great question. Cognitive impairment is the leading cause of loss of work in the United States from MS, cognitive impairment and fatigue. It's an invisible symptom, and it's a terrible symptom. It's insidious. This is not an Alzheimer's dementia where you're not sure who you are or the people around you, but this is a problem with multitasking, with executive functioning, with rapidly thinking, and it's insidious, meaning it doesn't always come on right away. And it can erode the quality of your life. It can make it hard to work. It can make it hard to have meaningful conversations even. And so, so wanting to improve fatigue and wanting to improve cognition is really, really important. Now, the question is, have I seen great improvements? And yes, I have seen great improvements. Not with all patients, but with some patients. And how do we manage cognitive impairment? How do we manage cognition? Well, as you can guess, it's not one size fits all, and it's not one modality. There are a lot of things that you need to do to beat cognition. So let's talk a little bit about them right now. Number one, we need to manage depression. Very frequently, I will meet someone with MS and they're suffering cog fog. They can't think clearly. And they are depressed and it's undertreated. And we treat the depression and the cog fog is lifted. You talk about a really big, robust response. Some of the biggest responses I've gotten is when we treat underlying depression and cognition and clears. And that's a real phenomenon called pseudo dementia we see in MS very frequently. And so one of the major things I want to do if someone's having some difficulty with thinking and memory is make sure that their mood is adequately sorted. That's the first thing. Getting adequate sleep makes a big difference. And many red-blooded Americans run around on 4 or 5 hours of sleep and they're exhausted and it takes a toll on their thinking and memory. Now that's an even bigger issue if you have MS because you got to recharge your battery. And so looking at sleep hygiene, finding out exactly how much you're sleeping, what's the quality of your sleep. If you have obstructive sleep apnea, treat it. If you have restless leg, treat it. If you're getting up to pee 5 times a night, fix it. If you're not sleeping because your husband's snoring, fix it. And managing sleep is very important. The next thing is to exercise because exercise actually improves cognitive function. And so if you're not exercising, we got to get you exercising. And if you can't go running, we'll throw you in a pool with a life jacket on and have you swim around, or we'll have you do share yoga or something. And we need to get you exercising. What else do we need to do? We need to look at drugs and alcohol. Sometimes people are having cognitive impairments and they're smoking or they're drinking too much or they're doing other things that can impair their sensorium. And so we have to look critically at drug and alcohol use. Now, I'm not trying to make judgment calls or tell someone they're naughty or bad because they've chosen a recreational drug. I'm just saying that it may impact their thinking and memory. So if they're coming to me saying, Aaron, I'm not thinking so hot, we have to think about that. Looking at polypharmacy, meaning the drugs and pharmaceuticals that doctors put you on. Sometimes the list gets too long. And it's striking that the average American with MS is on 7 medicines. Doctors are very good at putting on a medicine. We're not very good at taking a medicine away. And so I think it's a reasonable thought every time you see your MS doctor say, what else can I remove off this list? Do I still need my antispasmodic? Do I still need my neuropathic pain medicine? Is this still important? And then lastly, there's other things we can do, like giving a stimulant medication. A stimulant medication can trick the brain into being more awake. And attention is one of the major issues with MS cognition. And so I have seen miraculous improvements sometimes in some patients giving them a stimulant. There's other things that we need to do about making sure that we use patterns during the day. We use trips and tricks to help us. For example, keeping a running list of things you need to do and checking them off, using Post-it notes. I also like a trick of helping stimulate thinking and memory by engaging in cognitive puzzles. You go to your grocery store and in the checkout line, you'll see a bunch of books, Sudoku, crosswords, word finds, things like that. Put those books in your bathrooms. And when you're sitting on the john, do a puzzle or two and make that cognitively a useful time. Or read a book and read the same book your spouse is reading and then argue about it afterwards. There's a lot that we can do to game out improving cognition. And yes, it can work. Not always, not in everyone, but there are times that we're really proud of ourselves that we've done a good job helping someone up their cognitive game. I've got several videos on my channel which go into some detail talking about this, so you might want to check those out if you haven't seen them already. And if I remember, I'll throw a link down in the post below. So let's see here. Someone else writes in, if a patient is already on methotrexate, can it help with MS? Is it true that MS trials with MS, what's the medicine? Methotrexate is an old oral chemotherapy drug, or it's an immunosuppressant. And so methotrexate is used in several different autoimmune diseases. It's also used in certain cancers. And it is used in MS, or it was used in MS. There's some data from the 1980s that it can decrease relapse rate. It's not very robust data. I don't think that methotrexate works better than interferon, for example, but it can be helpful. There was some early research also looking at intrathecal methotrexate, so injecting it into the thecal sac for really aggressive MS, but that research never really took off and evolved. Methotrexate is not something that I regularly use to treat MS, but sometimes I'll have a patient that has MS and lupus or MS and rheumatoid arthritis, and they're on methotrexate, and that's okay. I think that it can be helpful. It does sometimes play a role in picking the next drug. Because methotrexate is a form of oral immunosuppression, we have to be thoughtful about what we move next to or what we add. But it's not a deal breaker, and it probably can help provide a low level of immunosuppression. So Ellie writes in, what do you do when patients' falls increase? And so falls are a major issue. I work very closely with several neurophysical therapists, and fall is a dirty four-letter word for those guys. We do not want you to fall. Falling is a risk of banging your head. Falling is a risk of shattering a hip. Falling is embarrassing. Falling is something that we want to fight against and to avoid. And so, first of all, when you see your MS provider, tell them if you've been falling. Say, hey, I've been falling. And tell them how often you've been falling. Try to pay attention to what was going on when you were falling. And see if we can identify, for example, someone with a walker who never ever falls out of their home, only falls in their home, and it's only when they're not using the walker when they're in the bathroom. If we can identify things like that, it can really help. But what do you do when someone's falling? Well, we need to think holistically. We need to look at their gait mechanics. We need to see, do they need rehabilitation? Do they have a foot drop or a weak hip that we need to fix with an orthosis or with an assist device? Are they deconditioned? Do we need to get them back into physical therapy or into an exercise regimen to strengthen them up? Do they have poor balance leading to falls? If so, we need physical therapy to retrain their balance. Are they having trouble feeling their feet? Or is their vision bad and they're not getting the right sensory information? Do we need to change the environment around them? Are they using an assist device? Is that assist device appropriate? Sometimes someone will use a cane and they fall the other direction. And so that assist device isn't appropriate. Are they cognitively impaired? Are they having difficulties with motor planning and executive functioning? Are we noticing other issues within their environment about safety? And so we can really get deep into the weeds trying to help someone fall less or not fall at all. We also have to think about their bone health. And men and women with MS over the age of 50 should be getting a bone density test every couple of years, because MS is an independent risk factor for thinning bones. And the worst thing that I could think of is a fall on Ohio ice and a shattered weak hip. That can happen, and it's devastating. And so for starters, if you have increased risk of falls, or if you're falling, tell your provider. And common things that we want to look at: cleaning up your medication list to uncloud the sensorium, working on gait mechanics, working on reconditioning, making sure the assist device is correct, making sure that we're adequately looking at sensory information like vision and sensation in the feet. Excellent question. Thank you for asking it. So Pam writes in, what's the difference between MS and NMO? So MS stands for multiple sclerosis, and this is an inflammatory condition. It's an autoimmune demyelinating condition that affects the brain and spinal cord. NMO, which stands for neuromyelitis optica, or used to be called Devick's disease, is a cousin of MS. It's also an inflammatory disease, and it affects the spinal cord and the optic nerves with much less involvement of the actual brain. And it's a cousin of MS. It's not the same thing. One of the differences is the fact that it doesn't impact the brain as readily. Another difference is NMO does not seem to progress. People with MS can have a progression of disability in between attacks. In NMO, there isn't really a progression between attacks. A third difference is that NMO attacks are very, very rough, and sometimes people don't bounce back. So early on in MS, it's not uncommon that you suffer an attack and you bounce back. With NMO, sometimes you don't bounce back at all. NMO tends to respond less well to steroids than MS. And so with NMO, oftentimes we can't use steroids. We have to use plasma exchange or pheresis. And NMO, the drugs for MS don't always work. The drug of choice in NMO is a B-cell killer like rituximab or off-label Ocrevus, something like that. But interferon medicines, interferon beta medicines, which are used in MS, actually make NMO worse. So even though they're related, they're cousins, they're very different. And hopefully that highlights some of the differences for you. That was a great question. Thank you for asking. So Martin writes, my beloved pain pill. I'm not going to talk about pain pills today. Sorry, it's too early on a Sunday morning. Kimber Gill writes, why do people with MS seem to find themselves in positions that others feel are uncomfortable, mainly with the legs? So I'm going to interpret this question about abnormal sensations in the legs. And there's a lot of reasons why you can have abnormal sensations in the legs from MS. So let's talk about a couple. There are several sensory systems that provide information from the surface of the skin up into the brain. And there's a sensory system that's responsible for light touch, for the movement of the joint, and also for vibration, if you feel it vibrating. And that's one set of wires that go from your legs up into your brain. There's a separate set of wires for temperature and for pain. So when you're pinched, there's a separate set of wires sending information up to the brain. So there's these two major sensory modalities. And if there's damage to the brain or spinal cord interrupting that, you could have change in pain and temperature with normal sensation of light touch. Or you might have abnormal light touch, but normal pain and temperature. My point here is that can be very confusing. And so it's not uncommon that people that have brain or spinal cord damage from MS can have a numb leg or a burning leg or a cold leg or an achy leg. And a lot of these can come from abnormal sensory pathways going up into the brain. Now, more can happen because, as I described earlier in this live stream, you can have spasticity. And spasticity can make it so the leg doesn't bend normally. When the leg doesn't bend normally, it's tight and it feels sort of sometimes squeezed or compressed. It can cramp and spasm, and that's a very abnormal sensation. Also, when the leg doesn't bend normally, blood can pool. And so when you don't have normal blood circulation, it can make your foot cold. It can make it change colors. And so there's a lot that can be going on. My point here is there's a lot of different pathology that can lead to changes in sensation in your legs. So thank you for that question. So we've got about a little less than 10 more minutes before I wrap up this live stream. Let me look at a couple other questions. So Ellie writes in, can you tell a relapse from a pseudo exacerbation? Can you get it wrong? So that's a great question. So in MS, we talk about an attack, a flare, a relapse, an exacerbation. That's when there's a new acute bout of neuroinflammation causing a new neurological deficit, like I can't see out of my eye, or my hand's numb, or my arm is weak. And there's some operational definitions that we use. We say that it's a new neurological deficit in the absence of a fever. And the reason we say in the absence of a fever is if you have a fever, your core body temperature is raised, and you have a new neurological symptom, or more likely an old one that's gone away and come back, that may not be a new attack. That may be the reemergence of old symptoms in the setting of a fever. So when someone calls into the clinic and says, Aaron, I have a new worsening, my leg's numb, One of the things we want to always ask them is there any chance of infection? Any burning when you urinate? Foul smelling urine? Do you have a fever? Do you have a cough? Are you coughing up green stuff? Because if you're infected, it's more likely to be a pseudo exacerbation. And if we identify, hey, you're coughing up green stuff, and we're concerned about, say, a community acquired pneumonia or a bronchitis, we're going to treat you with antibiotics, not with steroids. Now, if we treated you with antibiotics and the cough went away, but the neurological symptom didn't, now we're concerned. We're going to revisit that question and say, maybe this did evolve into an attack. The point is, the human being doesn't know it's an attack or it's a pseudo attack or it's something not neurologic. The human being simply experiences some symptoms. I implore you, you have to bring this to the attention of your provider. You have to tell your MS provider, I have these symptoms, and then work with them to figure it out. How do we do that? Take a careful exam. We oftentimes send urine for urinalysis. We use a stethoscope and listen to your lungs, and we try to sort that out. And as a team, oftentimes we can sort it out. On your own, it can be very, very challenging. So let's see here. What else is going on? I've got Lynn writing, after a holiday in Turkey, I feel that my symptoms have become worse. Why is that? That's a great question. And I actually have a couple videos about travel. Traveling is taxing to the human body. Many of us have a pseudo-sedentary lifestyle and very, very standard patterns where we eat about the same time every day. We go to bed about the same time every day. We take a walk about the same time every day. And we have these patterns that we become very comfortable with. Now, when you go on a holiday in Turkey, which is on the other side of the world, you're on a plane, you're eating weird food, you're not sleeping normally. When you're in Turkey, you're having to travel and walk a lot, and you're having to change how you eat and how you sleep and the climate. And there's enough change in your environment. It can be very, very taxing. Oftentimes in the United States, I will talk to families with MS that come back from Disney World, and they are not doing very well. And some of these patients may even spend a week in bed recuperating. And I remind them that on their voyage to Disney World, they walked more than they've walked in months, that they've been up on their feet for hours and hours and hours where they're never doing that normally at home. They're eating lots of sugar-laden foods and maybe drinking some alcohol and maybe not drinking a lot of water and maybe staying up really late at night, and their patterns are changing. And that can be very, very taxing. I did a video right around the Christmas time talking about surviving the holidays. And some of those tips that I share apply to traveling abroad. So if you haven't checked out those videos, you might consider doing that. It's an excellent question, and you're not alone feeling that way. Many people, when they go on a big trip in the setting of MS, they do fine during the trip, and then they pay the devil's price afterwards. Thank you for bringing up that question. So Divine writes, after surgery, should a patient wait on a certain amount of time before switching a disease-modifying therapy? So depending on what surgery we're talking about, and depending on what disease-modifying therapy we're talking about, will determine how we answer that question. So the key here is, if you're going to have a surgery, or if you think you might need a surgery, tell your MS provider, say, hey, I'm going to have X or Y done. Because depending on what drug you're on, we might need to be planful. We might need to use special antibiotics. We might need to delay the surgery. We might need to check some laboratories. We might, in some cases, need you to come off your medicine for a bit to have the surgery, then go back on. And so the way that we would sort that out is by knowing what is the surgery and what is the drug, and then we can put all the pieces together. And very often, the MSologist will talk to the surgeon, and they'll have a communication, and they can sort that out. And so you want to be planful. I give an open opportunity for the surgeon to reach out and call me, or I will reach out and call the surgeon, so that we can make sure that we're communicating and that we do the best thing for that patient. Great question. I'm going to take one more, and then I'm going to wrap this up. I'm looking for one more question. There's a lot of great comments here. I want to see if I can find one last question. Okay, here's one. So Diego writes, do you hit hard with Lemtrada or Ocrevus with clinically isolated syndrome? So I have an opinion that if we use the most effective MS medicine as early as possible, that we have the best chance of a long-term outcome. That is a belief of mine. And I try to apply that opinion when and where I can. Now, there's lots of things that make that sometimes hard. For example, Lemtrada in the United States has a label that it's used third. So you can't start it as the first drug. You can't start it as a second drug. You have to start it as the third drug, which is really, really unfortunate because it was studied to be given first. And it works really well when you give it sooner. But the American FDA's law says that it's not a good recommendation. And so third-party payers oftentimes won't allow me to use it early on. If I was allowed to use it earlier, I might. And so there are some systemic things that can prevent me from executing my desire, which is to put you on the most effective drug you're comfortable with as early as possible. It is a dream of mine that we can use highly, highly effective medicines with the first MS attack, because I truly believe that if we did that, it would change the face of the disease. It would change the trajectory of the disease for that human forever. And it's my hope that as we move forward in time and people become more enlightened about how we need to beat up this disease, that those options will become available. That was a great question to end on. Let me wrap up here, guys. My name's Aaron Boster, and thank you for jumping online on a Sunday morning randomly to talk with me. I'm really enjoying these live streams, and I really appreciate all the people that have jumped on. There's 81 people online right now. That's amazing. I haven't done a good job of letting people know ahead of time, and I'm going to work on that. I'm not sure about the cadence. I'm thinking I might do a live stream once or twice a month. They'll probably be on weekends because that's easier from a work standpoint. And I've been doing them in the morning just because my family's upstairs asleep. And so that way I'm not interfering with family time. But I'm going to make an effort to try to announce that I'm doing them a bit earlier to give people a chance to get ready and to attend if they want to. And as always, this is going to go into the YouTube channel. So if they missed it, they can jump and they can watch it later. I also plan on going through all the questions, and I'll probably do an after party video where I answer any questions I didn't get to. This is, again, something special to me. It's special that this community is growing. And I love hearing from you guys. Please take a moment, and if you're watching this in the replay, leave a comment down below. And thank you for caring. Thank you for sharing with me. Thank you for learning about MS with me. So until my next video, this is Aaron Boster saying thank you. Have a great week and take care.